Just a brief introduction from PNMDP. So we are pediatric and neonatal multidisciplinary developmental program of Pakistan. Our main aim is to improve skill knowledge of our trainees, and it's just not for the trainees. The pediatricians and neonatologists can attend as well, just to upgrade the skills. And we are planning for different workshops and sessions and involving the multidisciplinary teams. And obviously, that will improve the outcome. And, this is our team, founder, board members, and members. And basically, we are also arranging a different session for FCPS, MCPS exams as well. So the mock test will be in February for talks and theory, and now you can have PCQs with explanation, and that is very useful for your exam and for your day-to-day practice. You can also watch our videos on YouTube, and that's just the at a glance section of from PNDP. So just a short description on important topics of 5 to 6 minute videos. And I think this is the last session from the neonatal week, and obviously we will start our new round from March till August, and then there are very interesting new sessions. We will post the link on our Facebook page. We are also planning for conducting, already conducted first workshop in communication skills. Second one will be in June. History taking and developmental station as well. If you are interested to join as a regional training representative, please email us. And please never forget to complete the surfactant survey that's on our page as well. And there's upcoming PNMDP interesting case presentation competition. And just encourage your trainees and to participate. And you can email us, and I can send you the form. And the last day to submit your presentation is before the 30th March, and we'll select 20 trainees. And never forget to complete the survey in today's session. And now I'm handing over to Dr. YASSER. So thank you so much. Dr. YASSER, please.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Yas, for inviting me and giving me the opportunity to talk about conventional mechanical ventilation in neonates. Can everyone hear me properly? Is the voice clear?
Yes, your voice is clear. Yeah, thank you so much.
Because when Ayaz was talking, the voice was not very clear. So just want to make sure that people can hear properly. So we'll start off with a brief introduction of myself. I'm a graduate of King Edward Medical College, and I did my FCPS in pediatrics in 2009 from Children's Hospital Lahore. And then in 2009, I went to UK and completed further training in pediatrics and neonatology. And most of my neonatology was in St. Mary's Hospital in Manchester, which is one of the biggest centers in the UK, with about 10,000 deliveries per year and about 69 beds. So that's my background. In today's session, just few housekeeping things. Ayaz has mentioned few things as well, but please keep yourself muted. I'll aim for an interactive session. So if you want to speak, please unmute yourself. Because this is the trial session, the session will end in 40 minutes. So you can then straight away rejoin using the same link. The learning objectives for today's sessions are that we'll discuss why we ventilate newborns, what ventilation parameters we should be using as in the start, and how we should modify them during ventilation, why we ventilate the babies, what are the goals of ventilation, what are different ventilation modes, and then how to act on poor oxygenation and over and under ventilation, and finally we'll touch on weaning and extubation strategies. I'll mention 3 cases, and so that people can just think about these cases, and we'll discuss them again at the end of the talk. And the first case is a 30 weeks preterm baby, 1.5 kilogram, no antenatal steroids, and intubated in delivery room and given surfactant. So what ventilation mode and settings will you choose? This will be our first case. And the second case is a term baby with severe hypoxic ischemic encephalopathy who is being admitted to the unit, and there was cord prolapse just before birth, and the baby needed intubation, and due to very poor respiratory effort, what ventilation mode and settings will you choose in this baby? And the third case, and that a term baby is coming back from theater after thoracotomy for tracheoesophageal fistula and esophageal atresia. What ventilation mode and settings will you choose? So these will be the 3 cases that we'll be discussing at the end after this talk. So we'll start off why we need to ventilate newborns. The commonest indication for mechanical ventilation in newborns is respiratory disorders, and that's our bread and butter on day-and-day basis. The respiratory conditions which need mechanical ventilation in newborns are the commonest are RDS, neonatal sepsis, congenital lung malformations, pneumothorax, persistent pulmonary hypertension of the newborn, congenital diaphragmatic hernia, tracheoesophageal fistula. So all these conditions, whether they are congenital or acquired, and the respiratory disorders, they are the commonest group of the conditions for which the babies need mechanical ventilation. After the respiratory is then the cardiovascular, so like significant, especially duct-dependent congenital heart diseases where the baby needs prostatin, or congenital disorders where there is a severe myocardial dysfunction which lead to neonatal heart failure. Those babies need mechanical ventilation. The third group, which is probably the commonest after respiratory, is sepsis. The babies with sepsis due to multi-organ failure need ventilation, and probably I think in Pakistan, after respiratory disorders, the commonest group of the newborns who need ventilation are the babies with neonatal sepsis. Then babies with a variety of metabolic disorders, and they can be encephalopathic, and they need mechanical ventilation. And then babies with a variety of neurological disorders, they need mechanical ventilation. And the neurological disorders which need mechanical ventilation could be either central or peripheral. And the way we ventilate them, again, depends on the underlying cause. The central causes, usually commonest is hypoxic ischemic encephalopathy, congenital brain malformations, and neonatal seizures. And in the peripheral causes, the commonest are where the newborn is too floppy to breathe, like SMA type 1 is the classical example of a peripheral neurological disorder which need mechanical ventilation. And finally, babies who are unwell because of surgical reasons, either pre-operatively or post-operatively, they need mechanical ventilation. The pre-operative, where we ventilate the babies, are congenital diaphragmatic hernia. Some babies with necrotizing enterocolitis, if they are very unwell, they need pre-operative mechanical ventilation. And in most other conditions, the babies will be electively ventilated just before surgery, and then they will be ventilated for a period of 1 to 2 days after surgery, based on the surgical condition that they had. So these are the broad group of disorders for which the babies need mechanical ventilation. And the reason I mentioned these indications in the start is because every disorder is different, and the mechanical ventilation strategies for each disorder will be different. So when we put the babies on the ventilator, the first thing I want to ask myself before putting the baby on the ventilator is that how are the lungs? What is the condition of the lungs? Are the lungs normal or not normal? And if they're not normal, what is the underlying pathology? Is it a preterm RDS, or is it a term baby who has some other pathology like meconium aspiration or pulmonary hypertension of the newborn, or sepsis, or any congenital lung malformation? So this is the first question that we ask. We need to ask ourselves that what is the condition of the lung? What is the status of the lung? The next question is that what is the condition of the heart? Is the heart normal or is the heart function impaired? And if the heart function is impaired, how much heart function is impaired? And then how is the brain? Is the brain normal or not normal? What is the respiratory drive of the baby? Is the baby breathing some breaths? What is the respiratory drive of the patient? What is the status of the kidneys? Is the baby fluid overloaded or is the baby passing good amounts of urine? And what are the other organs like gut, liver? And the last question we need to ask is how long the baby is expected to stay on the ventilator, because that again will determine our ventilation strategy. So these are all very important but relevant questions that we need to ask ourselves when we are starting mechanical ventilation in newborns, because that will dictate that what ventilation mode we should use and what ventilation strategies we should use, and whether we should be using sedation or not. Again, it all depends how long we think the baby is going to stay on the ventilator. So as we speak, there are two ventilation modes available right now. There are pressure control ventilation modes and there are volume guarantee ventilation modes. And we'll talk about these two modes in today's talk. If we're using pressure control ventilation modes, then there are certain parameters that we need to set before we start the ventilation. The first thing we need to set is the peak inspiratory pressure, that how much pressure we want to give to the baby with each breath. That's peak inspiratory pressure. The next thing we want to set is the peak end expiratory pressure, that how much should be the PEEP, that should be the baseline, which should be static all the way through the expiration. And that is the pressure which will keep the alveoli distended throughout the respiratory cycle. The next thing we need to set is the I time, that how much time the baby should spend in inspiration and how much time the baby should spend in expiration. If we're using PSV mode, then we don't need to set the I time, because it's the baby who decides the respiratory rate and the I time. Then we set the respiratory rate and the FiO2. So these are the 5 different settings that every baby who is going on the ventilator while using pressure control ventilation mode, we need to set. Now, if it's a preterm baby, then the PEEP is generally set around 18 to 20, but that again this is just a starting point. And once the baby has been started on the ventilation, then depending on how much tidal volume the baby is generating, that PEEP will be altered. The PEEP is generally set around 4 to 6. The I time is set around 0.3 to 0.4 seconds. The respiratory rate is set, again, depends on the patient's respiratory drive as well, but generally the respiratory rate is set anywhere around 40 to 60. And the FiO2, depending on the patient saturation, could be anywhere from 21% to 100%. So what happens in pressure control ventilation? In pressure control ventilation, the peak inspiratory pressure is fixed. So we tell the ventilator that I want you to deliver a PEEP of 20 with each breath. So the ventilator will deliver a pressure of 20 with 20 centimeter of water with each breath, but then the tidal volume will be variable depending on the lung compliance and the underlying pathology. So for each baby, depending on its individual lung condition, the tidal volume will vary. So what we need to do if we're using pressure control ventilation, that once we have started the ventilation, we need to keep a very close eye on the tidal volumes and then adjust the PEEP up and down to achieve a tidal volume of 4 to 6 mL per kilogram, or even higher if oxygenation or ventilation is difficult. So if we're using pressure control ventilation, we're telling the ventilator that this is the set PEEP that we want you to deliver, but then the tidal volume will be very variable. And in the first few hours, we need to adjust the PEEP very closely to achieve a tidal volume of 4 to 6 mL per kilogram. And this is especially relevant in babies with RDS, because after giving surfactant, their lung compliance improves dramatically. So if we don't wean the pressure, the tidal volume will dramatically increase, and that will cause significant valvular trauma. If we are using volume guarantee ventilation, which is now becoming a preferable mode of ventilation in newborns and in most modern NICUs these days, the volume guarantee ventilation is the preferred mode of ventilation rather than pressure control ventilation. The slightly different settings that we will need in volume guarantee ventilation. And the most important and the first one is that we need to tell the ventilator that how much tidal volume I want you to give to the baby. So that's called target tidal volume, TTV, and that's usually set at 4 to 6 mL per kilogram. Then as a safety mechanism, we also tell the ventilator that do not go beyond this certain pressure. So for example, in preterm babies, we set that pressure at 25, and in term babies, we set that pressure at 30. So the ventilator will not go above that Pmax. And if it is needing to give pressure higher than the Pmax, then it will start alarming, and that should alert you that there's something wrong, that the ventilator is needing a very high pressure to deliver our target tidal volume. Just like pressure control ventilation, we will also set the PEEP, which is again anywhere between 4 to 6. The I time is 0.35 to 0.5 seconds. Again, in PSV mode, we don't need to set the I time because the baby decides its own I time. We'll set the respiratory rate like in pressure control ventilation. And again, the FiO2 will be variable and dependent on patient saturations. So these are the settings that we will use if you're using volume guarantee ventilation. So in volume guarantee ventilation, as I mentioned, the tidal volume is fixed. And what will happen, the peak inspiratory pressure generated will then be variable depending on the compliance of the lungs. If the lungs are, the compliance is better, especially after giving surfactant, the PIP will generally go down. And if the lungs are stiff, for example, in meconium aspiration or in babies with severe chronic lung disease, the PIP will be higher. Once we have started the ventilation, we need to keep a very close eye on the peak inspiratory pressure generated and then adjust the tidal volume based on gases, FiO2, and the clinical condition. If the baby is needing a very high peak inspiratory pressure, then you might need to increase your tidal volume if you have started off with low tidal volume. But what we are aiming is we're aiming for high saturations above 93-94% with the tidal volume of 4 to 6 mL per kilogram. Once the patient is on minimal tidal volume with good gases, minimal FiO2, and minimal peak inspiratory pressure, and then we can consider extubation. So before we move on, I just want to ask if there are any questions about what we have discussed so far about volume control and volume guarantee ventilation, because these are very, it's very important that people understand clearly the difference between the two modes, and then we will move forward. So if anyone wants to ask any question, you can unmute yourself.
Can you describe indication of both pressure and volume ventilation?
Once again.
Sir, can you explain indications of both modes?
Okay, we will discuss a little bit later on in the presentation, but these days, the preferred mode of ventilation for all indications for mechanical ventilation in newborn is that we start off with volume guarantee ventilation. That is the preferred mode of ventilation these days. And that is, there is very strong evidence now that volume guarantee ventilation is much better than the pressure control ventilation. However, I will explain later on in the presentation that in some babies, the volume guarantee ventilation doesn't work for a variety of reasons. And in those babies, then you should be considering pressure control ventilation. So the simple answer to your question is that these days, the volume guarantee ventilation is the preferred mode in each baby, but in some babies, it may not work for a variety of reasons. And then in those babies, we'll revert back to the pressure control ventilation. So there's no set indication as such. For most babies these days, the volume guarantee ventilation is the preferred mode. Okay. So I just want to ask the participants that what are our goals of ventilation when we are ventilating the babies? What do we want to achieve? So if anyone can answer this question, you can unmute yourself.
Sir, to deliver appropriate oxygenation and ventilation.
Yes, very good. So there are basically two goals. Excellent answer. Very good. So the two goals of ventilation. There are only two goals. One is that we want to. I should rather say goals of mechanical ventilation rather than goals of. I'll actually change it now. Otherwise, I'll just confuse you. So there are two goals of mechanical ventilation. One, that we want to oxygenate the patient, and the other one is that we want to ventilate the patient. So how do we oxygenate? What determines the oxygenation? Again, people can unmute and answer this question. What determines oxygenation?
Saturation of oxygen in the blood.
Saturation of blood, oxygen. You mean FiO2 or?
Inspiratory pressure.
Okay, inspiratory pressure. Yes. What else?
FiO2.
FiO2. What else?
Peak inspiratory pressure.
Peak inspiratory pressure. Yes.
Inspiratory time.
Respiratory rate.
No, don't. Respiratory rate doesn't affect the oxygenation. There's one thing which.
Partial pressure of oxygen in the blood.
Keep partial pressure in normal range.
Sorry, say again.
To keep the
Peak
partial
inspiratory
oxygen,
pressure.
the partial pressure of oxygen in
Presence of
normal
any
range.
Inspiratory time.
So there's one answer I wanted to hear, which I've heard one answer, and there's one thing which I wanted to hear, which I didn't. So there are basically two factors which affect oxygenation. The first one is your FiO2, and the second thing which affects your oxygenation is the mean airway pressure. So this is a really important point to remember for everyone. But these are the only two factors which determine that how we oxygenate the baby, that how we can make sure that our baby saturation is maintained above 93-94%. First one is FiO2, which can be anywhere from 21% to 100%, and the second is your mean airway pressure. So these are the only two factors which determine your mean airway pressure. So what is mean airway pressure? Anybody?
When we are ventilating a baby, the mean airway pressure will be somewhere between PEEP and the average pressure between PEEP and the inspiratory pressure.
Anybody else?
Peak inspiratory pressure minus peak in expiratory pressure.
Anybody else? So
this is the pressure required to maintain your oxygenation.
So yeah, so mean airway pressure is quite a complicated formula, as you can see. We don't need to remember this formula as such, but essentially it's PEEP times inspiratory time, and then PEEP times expiratory time divided by sum of your I time and expiratory time. We don't need to remember this formula because the ventilator will do this calculation for us. But what we do need to remember is that in a diagrammatic presentation, that's how the map is determined. So that's the solid line. You can see this is the peak inspiratory pressure, and then it comes down, and that's your PEEP. If you want to, and the area under the curve is basically mean airway pressure. So that's how you should remember. The area under the curve is mean airway pressure. So if you want to increase your mean airway pressure, or if you want to increase your area under the curve, then that's what you need to do. You can increase your peak inspiratory time. You can increase the PEP, you can increase the I time, you can increase the PEEP, or you can increase the respiratory rate. So all these things which are written at the bottom of this diagram, those can increase the area under the curve, and then hence they can improve the oxygenation. So, and all the things that you mentioned before, like increasing the peak inspiratory pressure, or increasing the I time, or increasing the PEEP, were actually correct answers. But what they're doing is they're increasing the mean airway pressure, and that is determining the oxygenation. At some point, whenever we discuss high frequency ventilation in a separate lecture, you will know that in high frequency ventilation, we are mainly working on the map, that what is our map. In conventional mechanical ventilation, again, we should be looking at map as well. And this is something that people should get into the habit of not only looking at the settings which are mentioned at the bottom, but also look at what is the map, because if the patient is not oxygenating, then you need to increase your map by using any one of these strategies which are mentioned. Like you can increase the gas flow rate. The normal gas flow rate is anywhere between 6 to 10 liters. So if your flow is less, you can increase that. You can increase the peak inspiratory pressure. You can increase the I time. You can increase the PEEP, and you can increase the respiratory rate. So all these factors can increase the area under the curve. And then when they increase the area under the curve, the map will increase, and that will improve your oxygenation. And what determines the ventilation? Anybody?
Ventilator rate.
Rate, yes. And what else?
Respiratory rate.
Related to
Removal of carbon dioxide.
Yeah, this, yes, rate. One is rate. What else? There's something else as well which determines your
PIP, PEEP, peak inspiratory pressure.
Tidal volume.
Yes, so the two factors which determine, one is your tidal volume and the other one is your respiratory rate. So we can if we are using volume guarantee ventilation, then you can straight away just change your targeted tidal volume, and that will affect your ventilation. So ventilation is your basically is your CO2 clearance. So if you're using a volume guarantee ventilation, and then you can just change the targeted tidal volume. But if you're using the pressure control ventilation, then you can alter the tidal volume by increasing your peak inspiratory pressure or by altering your PEEP. And the other factor which can affect your ventilation or CO2 clearance is respiratory rate. Basically, if you want to remember in simple words, it's your minute ventilation which controls your ventilation. So your respiratory rate and your tidal volume. You can see that from this, that if you're using volume guarantee ventilation, it's quite easy to control the CO2.
जब जिसकी हमने मैग्नीशियम 0.3 ml डाला था.
So coming on to the modes of ventilation, if we're talking about pressure control ventilation, the modes that we frequently use these days are SIMV and assist control mode. The IMV is also a pressure control ventilation mode, but this is not used anymore. And the pressure support ventilation is also a pressure control ventilation mode, which is used less frequently. The one in red are the ones which are more often used, and these are the ones that you should try to get familiar with. So the one is SIMV and the other one is assist control. And these are the ones we'll be focusing on in today's presentation. And then if you're using volume guarantee ventilation, that can be used with any of these modes. So IMV, as I mentioned, is not used these days, but from the diagram, you can see that there's no synchronization. So these, the solid black lines are the ventilator breaths, and the dotted black lines are the patient breaths. And this, so you can see there's no synchronization at all between the ventilator breaths and the patient breaths. And this asynchrony is not good, and that's why the IMV is hardly used these days. I think the only time that we use IMV is when we are transporting the babies, or if the babies are totally paralyzed. So SIMV is the mode that is one of the commonly used modes these days in newborn mechanical ventilation. It's one of the synchronized modes. So the ventilator will always synchronize baby's effort with its own breaths. And intermittent mandatory means that there are a certain number of breaths which is like a backup rate, which will be mandatory breaths, and the remaining breaths, which the baby's own breaths or spontaneous breaths, they will be unspotted. So synchronized intermittent mandatory ventilation, you can see that in the mandatory breaths, these are the mandatory breaths and these are the spontaneous breaths. In the mandatory breaths, as soon as the baby tries to take the breath, the ventilator will support those breaths, and these are the baby's own breaths, and these are unspotted breaths. So that's synchronized intermittent mandatory ventilation. The second mode, which is used, and this is one of the most favored mode, I would say that probably the first line of first choice of pressure control ventilation mode these days is the assist control mode. Depending on which ventilator you're using, the names might be different. Like in Drager ventilators, it's called PCAC, assist control. But if you're using the other types of ventilators like SLE ventilators, in those ventilators, this is called SIPPV or PTV. And the difference between assist control and the SMV is that in assist control, all the breaths are supported. So whether they are, all the breaths which baby is taking will be supported by the ventilator. However, there will be a backup rate, which will be mandatory breaths. So that's the explanation of the assist control mode. Every breath will be supported by the ventilator, but certain number of breaths will be the mandatory breaths, depending on whatever backup rate has been sent.
Sorry, Dr. Yasser, I think we have 1 minute over here, so we can go to the next meeting, please.
Okay, shall we leave this meeting then, or?
Yeah, we can leave this meeting and we can join with the same meeting ID.
Okay.
That's fine. Thank you so much.